So small bowel obstructions occur at a rate of 20 per 100,000 in the U.S. population. Adhesions are the leading cause in the industrialized countries. That's about 70% of the small bowel obstructions that we see. 12 to 16% of surgical admissions and more than 300,000 operations annually in the U.S. It represents about $2.3 billion in the healthcare expenditures. So obviously not a small thing, something that most of us probably deal with on a daily basis almost. The old dogma was never let the sun rise and set on a small bowel obstruction. That was more from an era when patients presented with more advanced disease, and surgeons worked with considerably less information than what we have today. So obviously that was before we had the thin slice CT scans that could tell us exactly what was there, what the obstruction was from, kind of give us a better idea of the bowel integrity, if it looks like things are compromised, those kinds of things. So if we're not going to operate on all these patients immediately, when is the best time to operate on them? So obviously there's still considerable debate over kind of when to operate on these patients that you're going to deem non-op initially. Really, you've got to kind of make that decision. Obviously, you've got the easy patients who are strangulated, have a strangulated hernia, something like that, have peritonitis, free air, all those kinds of things. That's simple. That goes to the operating room immediately. It's those patients that you think you can manage non-operatively. When do you kind of pull the trigger and take them for lysis of adhesions? Obviously, you want to balance avoiding an unnecessary operation, so somebody that may have eventually opened up, with the increased morbidity and mortality that can come along with waiting a longer length of time, as well as balancing those unnecessary operations with a decreased length of stay in today's kind of healthcare. Non-operative management of small bowel obstruction is appropriate in almost all cases of small bowel obstructions, like I said, except those patients that have an acute abdomen. So those patients that are strangulated bowel by adhesions, hernia, or volvulus, have free air and are septic with surge response on presentation. We've always talked about complete versus complete versus partial small bowel obstructions in the past. But really that doesn't, from the standpoint of kind of this talk, you would want to think more of it as an operative small bowel obstruction. That's somebody that you're going to take immediately to the operating room, versus a non-operative obstruction, somebody that you think you can give the time to, that you can wait and see if they'll open up. And those can be in both the complete small bowel obstructions and the partial small bowel obstructions. Those complete small bowel obstructions, as we've traditionally labeled them, actually even resolve in 41 to 73% with non-operative management. Progression to bowel ischemia in a partial small bowel obstruction is very low. That's about 3 to 6%, and that's usually in someone who has unhealthy bowels, so maybe an inflammatory bowel disease kind of person. Usually the low, kind of slow stretch of a progressive small bowel obstruction will not cause bowel ischemia. Non-operative management is successful in those partial small bowel obstructions in 65 to 80% of patients, so the vast majority of patients that present to us. And then signs of intestinal ischemia, kind of things you can look for in your CT scan that give you an idea that maybe you should take that person to the operating room, or things that you can look for in the patient or the CT scan that make you think take them to the operating room faster, will be obstipation for greater than 24 hours, mesenteric edema on the CT scan, and then an absence of a small bowel feces sign. So that tells you that it happened fast as opposed to kind of slowly, still passing some fluid through over time. So how many sunsets? That's the question. When do you take these patients to the operating room? Current literature would suggest intervention at 2 to 5 days after initiation of non-operative management. That's still a pretty wide margin there. Data would suggest delay in surgery for small bowel obstruction should not exceed 5 days due to an increase in mortality and longer post-operative stays. And then what is actually done is kind of highly variable. And obviously part of that depends on our gestalt and kind of what patients that we are quicker to take than others. But that's the thing, is a lot of this is very surgeon dependent. So how can we decide what patients are going to need to go to the operating room in a timely fashion so that hopefully you can make that decision earlier and get those patients to the operating room earlier, hopefully avoiding any sort of complications that come with a delay to the operating room, as well as making sure that you're not operating on somebody that would have opened up. Kind of the latest thing that we've been doing, and what a lot of studies have shown is beneficial, is to do water-soluble contrast. So kind of a gastrographin challenge in these patients, even after they've had the CT scan. So you give them a day or two, kind of, again, it falls into a lot of this as surgeon preference, but give them a few days of decompression and then do a gastrographin small bowel follow-through. Gastrographin draws fluid into the lumen of the bowel due to its hypertonicity. It will help decrease the intestinal wall edema, stimulates intestinal peristalsis, and has been found in several studies to improve bowel function and can actually decrease length of stay. So it can promote kind of resolution of these obstructions in some of these patients who we're going to resolve, essentially. An appearance of contrast in the colon at 4 to 24 hours after administration predicts resolution with a sensitivity and specificity of 96 to 98%. So it can give you good information when it does what you want it to, help these patients wake up a little bit faster, but still the question is kind of when do you do that? So as far as improving length of stay, admission to a surgical service results in a shorter length of stay, fewer hospital charges, shorter time to surgery for those patients that fail non-operative management, and a lower mortality than patients that are admitted to the medical service. Obviously, this is a little bit confounded by the fact that most of the time these patients who are getting admitted to medical services are a little bit sicker, but evidence would suggest that admission for small bowel obstruction to a surgical service can be beneficial. Implementation of a hospital-wide protocol has been shown to decrease time from admission to operation from 0.9 to 0.5 days, with a mean decrease in hospital length of stay of 2 days, so quite significant from a length of stay standpoint. And here, this is from surgery 2012. It's tiny, but this was their algorithm that they instituted and found those differences there, the decreased length of stay as well as the decreased time to operation. And this was just their hospital-wide protocol that they introduced. It gave very specific things for as far as who got admitted to a surgical service versus a medicine service, kind of guidelines for initial treatment after that. So kind of the evaluation there of them getting a CT scan, and based on that CT scan was how they would help decide what service they would go to, kind of the medicine service versus the surgical service, the initial treatment, and then just some little ones down there at the bottom is basically the people who are appropriate for admission to a medicine service. So patients that you think may have metastatic disease from cancer, the kind of chronic opioid gut people who don't truly probably have an obstruction, those kinds of things. And like I said, had quite an improvement in their length of stay as well as a decrease in the time to operative intervention for these patients. What still kind of doesn't come into play even in this protocol is exactly when you take these patients to the operating room. That's still very surgeon dependent, and something that you have to make to some degree on a patient-to-patient decision. So kind of putting that all together, so initial kind of recognition of that acutely operative small bowel obstruction versus a non-operative small bowel obstruction. So that's not difficult at all, honestly. Those are the sick people versus those patients that you can put an NG tube in, watch, wait. Obviously, would have to do serial abdominal exam, serial labs. Admission to the appropriate service. So for the most part, that would tend to be the surgical service that would be making the operative decision. Trial of nasogastric tube decompression. Kind of when followed by a gastrographin challenge, you can find papers that's from anywhere for 2 hours up to 48 or 72 hours. There are actually some who now are placing an NG tube, decompressing them for a couple hours, giving them gastrographin, keeping their NG tube clamped for 8 hours. Unclamping their NG tube, watching them for 8 hours, again getting a KUB, and if the contrast isn't in their colon, taking them to the operating room. So that still is kind of the area of controversy, is how long is your trial of nasogastric tube decompression, and then when to do the gastrographin challenge. And then exploration if no contrast in the colon at 4 to 24 hours. Right now, from our standpoint, what we do for the most part is hospital day 3. We'll give them a gastrographin kind of small bowel follicular challenge, see where the contrast is kind of later that evening, and make a decision first thing hospital day 4 about what patients to take to the operating room versus those who we'll call resolved after if we see the contrast in the colon. So that's kind of where we stand at this point in time. So.